Hi, everyone. Welcome. We're going to give it a couple of seconds for people to come in from the waiting room, and then we will get started with our webinar. Okay, I think we have everybody in. Welcome again. I'm Jenny Gaines. I'm the Director of Programs and Services for F.E.A.S.T, and we're so glad you're here for our webinar today. I want to give a special thank you to Kartini Clinic for sponsoring this session. And the topic of our session today is what constitutes good medical care for pediatric eating disorders. And we're fortunate to have Dr. Julie O'Toole here to speak with us on this topic, a very experienced pediatrician and a recognized expert in the treatment of pediatric eating disorders. Before we turn it over to Dr. O'Toole, we're just going to go over a couple of housekeeping guidelines. Thank you for joining us again, and please remember that we want you to keep your cameras off and your microphones muted during the presentation. And please feel free to put any questions that you have into the chat box during the question and answer portion of the webinar at the very end. We will be able to have Dr. O'Toole answer your questions. And with that being said, well, I'll turn it over to you, Dr. O'Toole, for your presentation.
Thank you, and good morning. I'm Dr. Julie O'Toole, and I'm very excited to be here talking to the F.E.A.S.T community. But first, I'd like to thank your Executive Director, Judy Krasna, for bringing us together today. I'm indebted to the patients and families that have been our teachers all of these years, and also to our staff here at Kartini Clinic for sharing our mission to care for children and youth with all conditions of disordered eating as if they were our own. Today I'm here to talk about medical care. I think it's an important topic, particularly for parents, not only to understand and navigate, but to be able to be proactive in the care of their own child. So let's get started. I look forward to the discussion afterwards. All right, so I have nothing to declare. Purpose of today's presentation, as I just said, is to talk about medical monitoring, which is essential for safety and recovery. Next slide, please. Next slide, please, yeah. So what I'd like to cover today, vital signs monitoring, growth and weight assessment, laboratory testing, talk a little bit about the importance of weight restoration and physiologic restoration for menstrual function in females, cognitive impacts of good recovery in both males and females, and then a little bit about communicating with healthcare providers as your child's best advocate. So you come to the doctor and you're very concerned and possibly scared. What do you need to be sure to mention to the physician beyond the fact she's not eating, or I caught her in her bedroom with little bags of vomit hidden under her bed, the kind of things that you will be saying no matter what. It's very important to mention any fainting episodes that have accompanied your child's illness, and talk about the timing of them and talk about what brought them on to the extent that you know that, or near fainting episodes of dizziness and vision changes, any heart rate abnormalities you may have noticed, a really low feeling when you check your child's pulse, heart rate, palpitations, chest pain. You probably won't have access to blood pressure readings at home, although some of you may. And temperature regulation issues. So if your child complains of always being cold, or they look blue and cold to you, you need to mention that to the doctor. Decreased exercise tolerance and unusual fatigue. Even kids who are exercising compulsively will often complain of being tired all the time. Next slide, please. So orthostatic vital signs. These are probably familiar to you, but basically orthostatic vital signs are changes in heart rate and blood pressure that happen when you're changing position. And here you can see the proper measurement technique. These slides will be available to anyone who feels they might be useful to them. So we don't need to go over proper measuring. It's good for you to have this as a reference. What does it mean, though, to be orthostatic? Really, orthostasis is not a measure of cardiac compromise so much as it is a marker for severity of illness. And what's happening is when we lie flat, we have a certain heart rate and a certain blood pressure because the heart is essentially coasting. When you stand up without any intervening sitting, that's not necessary and it's deceptive. When you stand up, now your heart has to pump uphill. And if the heart muscle, which is a muscle, has been wasted by starvation, essentially, then it's not going to be able to beat stronger, which is what a healthy heart does. You stand up, it has to pump uphill. The muscle just beats stronger to achieve the same volume of blood to the brain, principally, and the rest of the body. If it's been weakened and it can't beat stronger, it will beat faster, trying to make up a blood volume. That's called orthostatic pulse changes, where the difference between lying and standing is extreme. When the heart can no longer compensate by beating faster, the blood pressure will fall. And that's called being orthostatic by blood pressure. Next slide. So standards vary a lot between institutions. Here you see what we use at Kartini Clinic. Most emergency rooms will say that a change in heart rate, an increase in heart rate greater than 20 beats per minute is qualifies you for being orthostatic. And many places will hospitalize kids with those changes. We feel that that's not necessary. We have a little bit higher standard. By the time you're above 35 beats per minute change, then you would qualify for a medical intervention. But what do you do if your provider isn't checking orthostatics? I think the only recourse is to ask politely. I understand orthostatic vitals are really important in evaluating children with eating disorders. Could we check these? You can also bring printed guidelines. If they won't pay attention to your suggestions or your guidelines and seem annoyed by them, you can request referral to an eating disorder specialist if available in your community. You can also, and probably should also, learn to check basic orthostatic pulse at home. There are commercial blood pressure cuffs available, and as there are commercial scales for weight available to families that will send the results directly to your phone, or better yet, to your physician for evaluation without your child being able to read them themselves. If you do check basic orthostatic pulse at home, document those readings and bring them to your appointment. Next slide, please. So this is how we do weights at Kartini Clinic. We have a blind weight protocol. It's very important that weights on an eating disordered child, regardless of their starting point, whether your child's weight is above average, at average, or below average, it's important that the weights be blinded. And it's important how you do them. First of all, no person, certainly no eating disorder person, but really no person should be weighed in their clothes. It's an absurdity of modern medicine that you go into your doctor. I think they'd weigh you with your purse over your shoulder if you let them. They should, and certainly they'll weigh you with your shoes on. It's ridiculous. It doesn't give you any kind of an accurate idea what a person weighs, but you need that idea for your children. So ideally, they would give a urine sample, and I'll talk about that in a minute, so that you're emptying the bladder. You want a dry weight if you can achieve it. They should be weighed in a hospital gown, or if you're doing blind weights at home, they should be weighed in their underwear. Patient facing away from the scale, unless you have one of the kinds of scales that will just send you the information and they never see anything. In the doctor's office, if they have one of those old-fashioned sliding scales, that's a bit of a problem because kids learn how to, the sound of the weights clunking in there, they can kind of tell where they are. But today it's much more common for digital scales to be used, which is much better. There need to be no verbal or visual cues from the provider, and certainly no comments about, wow, you've lost a lot of weight, or wow, you've gained a lot of weight, or wow, I thought you'd weigh less than this looking at you. The weight needs to be recorded, but not disclosed to anyone but the parent. If you can achieve consistent conditions, like weighing someone the same time of day, preferably in the morning after voiding, that's ideal. Next slide. Oops. I think we skipped over the, or maybe perhaps not. Let me just, thank you. Yes, I think that's right. I think probably everyone, every parent anyway, and most providers have seen these CDC growth charts for girls, and there are equivalent growth charts for boys. Growth charts are really, really critical later on for understanding goal weights, ideal weights, expected weight for health, whatever you want to call it. You need, if wherever possible, to have the information that a growth chart gives you. You can see from these growth charts, they're age adjusted for children, and you can see the percentiles listed on the side. It's important to have a historic look at an individual child's growth pattern. Some children grow perfectly normally on the 10th percentile. Some kids grow perfectly normally on the 90th percentile. It is the change from their own personal percentile that you need to know about, and that's alarming. And don't let anyone tell you that because they are still on the growth chart, that there's not a problem. This is one of the most common mistakes that we see, where a pediatrician will conscientiously track the growth on the growth chart. Let's say this child was tall on the 75th percentile for height and on the 75th percentile for weight, and now suddenly is on the 50th percentile for weight over the past 3 months. This is a big, big problem. But pediatricians will sometimes say, well, she's still on the 50th percentile. Or even worse, the child who normally grows on the 90th percentile and now suddenly is found on the 70th percentile will be just as sick as a child who started on the 10th and fell to below the 3rd. But such a child will often be told, well, this is actually an improvement. You were overweight before, and now you're approaching normal. This is a catastrophe. And if somebody tries to tell you that, or worse, tell your child that, you know you need to seek another opinion. Next slide, please. So the growth chart allows us to track an individual growth trajectory, as I mentioned. And it will eventually help us establish appropriate goal weights based on an individual's own history. Next slide, please. Next slide, please. Okay. Let's move on to talk a little bit about basic lab work. But before we do, I want to say something important. Labs are not nearly as important as vitals and the growth chart. You can make a diagnosis and you can assess severity of illness just with the growth chart and the history. You don't need labs, and labs can be very misleading. I can't tell you how common it is for me to hear from a referring pediatrician that I don't think she's that sick. All of her labs are normal. If you have restricting anorexia nervosa, all of your labs, at least the kind that the pediatricians look at, will be normal. And you should not be falsely consoled by normal labs. So a basic metabolic panel, which most family doctors, pediatricians, PAs, nurse practitioners will obtain, are important, particularly if there is any vomiting or purging. In the person with restricting anorexia nervosa, sodium, potassium, chloride, bicarbonate are going to be normal. In a person who is vomiting and therefore losing stomach acid, they are going to have an elevated bicarbonate. They may have a low potassium. They can be in a lot of trouble medically. And that's why it's essential, whether or not you think purging is involved, to check electrolytes. Blood sugar level is very important. Very low glucose levels, blood sugar levels are common in restricting illnesses. You also should check BUN and creatinine. Your doctor should check BUN and creatinine because these are gross parameters of kidney functioning. Now, we always get a complete blood count, and most doctors do. But it's important to understand that for most eating disorders, the blood count is going to be completely normal and therefore deceptive, even in a very sick child. Ironically, counterintuitively, really sick kids with restricting eating disorders will very commonly not be anemic, will have normal protein in their blood and normal electrolytes. They may have low white blood cell changes, depending on white blood cell counts, depending on how sick they are. But it is entirely possible to be very, very ill and have a normal complete blood count and basic metabolic panel. Next slide, please. This is some of the eating disorder specific advanced lab work that we get. We check thyroid function. That's not that unusual. We also check sex hormones. These are going to be the individual parameters that you need to know about in order to evaluate where your child is on their individual weight restoration trajectory. When at normal weight for them, their estradiol should be normal, their LH should be higher than their FSH and so forth. In males, we check testosterone. We always also check glucose and insulin levels, particularly in children whose baseline is higher, children of higher body weight. Remember that it is possible to develop an eating disorder even if you have a very high body weight. For example, the 16-year-old girl who, before she got sick, weighed 210 pounds, lost 50 pounds, may have metabolic syndrome due to the metabolic issues that result in this high body weight, and anorexia nervosa, losing 50 pounds by restricting and exercise, and be very, very ill and need hospitalization. And yet nobody takes it seriously because they don't consider her to be underweight. Next slide, please. We also obtain some nutritional status markers. These are unusual for the general pediatrician, so you may not see these. Complement C3, complement 3 is a marker of nutrition, short-term nutritional sufficiency. And we check some of these other labs, including liver function tests, phosphorus. Possibly the only really critical one on this slide is the phosphorus. Phosphorus is essential to all cellular functioning. It's the central molecule in ATP, which is the reason that we can walk around and metabolize and generally supports life. Phosphorus can be driven into the cell where it is not available to the heart. That's the critical organ. And therefore, you can stop the heart by having very, very low phosphorus. So phosphorus needs to be tracked during refeeding. It's one of the things that can happen in the so-called refeeding syndrome, where the phosphorus drops with refeeding. Normal, when you start to refeed, the phosphorus drops. There are some things you can do, your doctor can do, give prophylactic phosphorus ahead of time, but it's just to put this little bee in your bonnet that you need to make sure that if your child's in the hospital or in a partial hospital or even an outpatient, that during the refeeding process, somebody is looking at their phosphorus, and somebody's looking at their phosphorus several times a week during initial refeeding. Next slide, please. So how often should labs be checked? It really depends on medical stability. In the hospital, you're going to be checking them. Sometimes you'd be checking them many times a day, but at least you'd be checking them daily. In the partial hospital, if you're checking metabolic labs, if the patient is stable enough to be in a partial hospital as opposed to a regular hospital, they should be checked monthly because they are going to help you track the adequacy of weight restoration, the female hormones and the male hormones. Higher levels of care require more frequent monitoring. I think that's self-explanatory. But always remember, labs are overrated compared to vitals in the outpatient setting. Next slide, please. The importance of menstruation. Now, clearly we're talking about not only females, but also females who are old enough to have ever had a period. So this would not apply to the 8-year-old girl with anorexia nervosa, or the 9-year-old boy, or the boy of any age, or a girl who had never achieved menarche, the first menstruation, because she had never achieved any pubertal changes. But in a girl who has ever had a period, or who is old enough to have had a period, and who has breast development and pubic hair, even though she's never menstruated, menstruation, its presence or absence, is an indicator of overall nutritional status. It is a critical biological marker of normalcy. It is a marker of hypothalamic function in the brain. It has a strong relation to bone health. But more importantly, it affects cognition. So without return to menstrual functioning, you will not get complete return to cognitive functioning. It's important to remember that return of menses requires not only restoration of weight, but also adequate body fat, and that return of menstruation can lag behind weight restoration, but it really shouldn't be long. In the past, the people have said, oh, well, you know, it usually takes 6 months to start having periods again after you've achieved a good weight. I don't think that's true. It doesn't take us 6 months. More likely, the treating provider guessed too low about what weight your child needed to achieve. So let's go on to the next slide, please. This is a really important takeaway. Birth control pills are not a treatment for amenorrhea. This has been debunked since probably the very early 80s, but you still will see practitioners faced with a child who is not menstruating because they have an eating disorder, start them on birth control to jumpstart their periods. Well, it jumpstarts nothing. What it does is it masks the degree of compromise that this young woman is experiencing, because those are not periods. All that the birth control pill does, besides prevent pregnancy, and sometimes that's what you need it for, is artificially build up the lining of the uterus. And then when you're taking the sugar pill component, it deprives the lining of the uterus of its hormonal support, and the uterus sheds it as blood. It has nothing to do with ovulation or normal menstruation. But more importantly, it masks an important marker of recovery. And the pill does not protect bone health like natural estrogen. Next slide, please. Okay, we're talking here about the cognitive impacts of anorexia nervosa. Another reason why parents sometimes and doctors often kind of miss how sick a child is, because they're still getting straight A's. And they believe that because she gets straight A's in school, her cognition is normal, and it's simply not true. Academic performance can be preserved for several reasons. High achieving personality traits is probably number one, and this has been noted in patients with restricting forms of eating disorders for hundreds of years. Overlearning and compensatory mechanisms. In high school, you can still get straight A's if you just do all the work. You show up in class, you're polite, and you turn in your homework. You can get straight A's. Once the kids reach college, though, and the work becomes significantly more abstract, if they are not cognitively restored, you'll begin to see them falter. Cognitive negative impact on cognition is often missed because they're not looking for decreased cognitive flexibility, trouble with novel problem solving, increased rigidity in thinking, and then, of course, social cognition changes. In other words, they become more focused on the homework, less normally focused on their friends and social life. All they do is study and study, become very focused on getting straight A's, on doing everything right, and are very rigid about how they do things. This is part of the illness. Next slide, please. Well, I don't think I need to convince parents about the importance of cognitive recovery, because of course, always staying slightly underweight and amenorrheic will have long-term impacts on their brain development. And although the brain experiences changes throughout life called learning, the critical growth of the brain really takes place up until about our mid-20s. So there we go. Okay. Cognitive recovery is connected to relapse prevention, and it improves with adequate nutritional rehabilitation. Just remember, full recovery takes time, even after weight restoration. You could, of course, undergo neuropsychologic testing, which would help identify subtle deficits, but then you'd have to have a series of neuropsychological tests. And this is really only important for research centers, but not for the concerned parent who wants their child to get well. Next slide, please. Okay, advocating with providers. This is a tough subject. What to do? A little bit, of course, is going to depend on where you are. You may have, if you're in Chicago, you live in urban Chicago, you may have access to a larger number of providers, a deeper provider pool than if you live in rural Utah. Or if you live in Salt Lake City, you'll have greater access to a deeper bench of providers than if you live in rural Oregon. So remember, if there's one surgeon in town, you don't want to offend that surgeon if you can help it. Now, that doesn't mean that you should just rubber stamp anything that surgeon or any other provider says. You need to be and are the most important advocate for your child that there is. Prepare for your medical appointments carefully if you can. Document your concerns. You can bring reference materials, but not too many, because providers will vary in their ability to accept what they see as you telling them what to do. Some people like me, I wouldn't care who challenged me. Don't have a problem with people challenging me, but I definitely know providers who have a big problem with being challenged by parents whom they feel don't have the background to understand what they do. So bring reference materials if you think they're going to be helpful, but not too many. Prioritize your questions. What are your most critical questions? Ask about any specific monitoring that you feel is not being done, such as orthostatic vitals. And request an explanation of any test results and their meaning. Those test results belong to you. Your child belongs to you. And the providers owe you an explanation for what they think they're seeing. Bringing a support person, as long as that person is calm and not threatening, and is truly a support to you, can be very helpful. For one thing, when you're stressed and you go to the doctor, it doesn't matter what your background is, whether it's me going to the doctor, you going to the doctor, my mother going to the doctor. If you're talking about critical medical issues, you are not going to remember what's being said. I often don't remember what my doctor told me, particularly if I'm upset about it. So bringing another person, another set of ears, can be very helpful. Doctors and nurses and PAs and everybody, dietitians, are going to be variable in their acceptance of you recording a session. I personally would welcome it. I think that it can be very helpful to listen to what the doctor, as shorthand for provider, said in the first place. But be sure you ask, and be sure they understand that you're not doing this because your brother is a lawyer. You're doing this because you're worried about your ability to absorb important information that they're giving you. Next slide, please. Effective communication strategies. Boy, is this hard to do. Stay calm, be direct, no heat, use we statements, frame any suggestions that you have as questions, like, I've read that monitoring orthostatic vitals is important. What are your thoughts on this? Or could you help me understand why you've decided to start her in the hospital instead of in the partial hospital, or in the partial hospital instead of going to my outpatient team? Acknowledge the provider's expertise while advocating for specific care for your specific child in your specific family. And focus on the fact that you share the goal of your child's complete recovery with them. Next slide, please. Okay, when to consider a second opinion. I think this is actually very important, because a second opinion, you should not be ashamed to ask for a second opinion. A second opinion is your right. And really, providers who are sensible welcome a second opinion. If your provider refuses to regularly monitor your child's vital signs, let's say you are very concerned about your child, they've been dizzy and have low energy and have lost a lot of weight, seem depressed, are isolating themselves from their friends, and your provider says, well, I'll see you in a month. That is definitely not adequate to address your concerns. Better would be, I'll see you in 3 days, or I'll see you next week. If, in your opinion, your provider is not taking your concerns seriously enough to monitor essential vital signs on your child, you need to seek a second opinion. if they dismiss your concerns about your child's physical symptoms, if they seem to lack eating disorder knowledge altogether, you'd be well advised to seek a second opinion, even if you have to travel. Now, nowadays, because we're all used to, thanks to the pandemic, we're all used to virtual appointments, it kind of expands the possibility of providers that we can seek, and that is a good thing. I don't know why I stuck navigating referrals and insurance at the bottom here, but that is something that you're going to have to learn how to do in order to advocate for your child. Is you're going to have to advocate with your insurance company for the best care that you can possibly find. Next slide. Okay. What are our key takeaways today? I hope. Medical monitoring is essential for safety. Just using anorexia nervosa as a model for a critical eating disorder, although children come with all kinds of eating disorders, of which anorexia nervosa is only one. ARFID, avoidant restrictive food intake disorder, is another where medical monitoring is essential for safety. Multiple systems need regular assessment. And your provider assessment of your child should be guided by their individual growth patterns and individual treatment goals. It's important to understand that cognitive recovery can lag behind physical recovery, and usually does, and that collaborative, informed advocacy, your advocacy, improves the care of your child. We think that recovery and remission is possible with early, comprehensive treatment. And as with all other human illnesses, the sooner you get the diagnosis, the sooner you intervene, the better the outcome. I think that's our last slide. Some resources, there we go. The Academy for Eating Disorders, the Society for Adolescent Health and Medicine, all have many publications and guidelines. We try to keep our information up to date, and we're also on YouTube for the purposes of educating parents. I wrote a book, a handbook for parents called Give Food a Chance. I don't know what to say about that. I hope it's useful. Next slide, please. Okay. Thank you. I hope we have some questions.
Thank you so much, Dr. O'Toole. I really wish that I had had all of that information when I was at the beginning of my daughter's journey. That was about 8 years ago. Hearing all of that just made me realize how we didn't have all the information that we needed at the beginning. Really appreciate you explaining, especially about the orthostatic vitals. And we did have some questions come up. One of them is about glucose measurements. Is that something that parents should be monitoring at home? And if so, is there a certain number that would be like the low number, like maybe we need to go to the emergency room with that number, or does it depend on the child?
No, I think I would be hard pressed to think of a circumstance where it would be useful for you to monitor glucose at home. I think apart from the metabolic work that we do that's independent of this with children of higher body weight and some other metabolic issues that pertain to eating disorders but are not the subject of this discussion today. Apart from that, we would just monitor an initial glucose, and then whenever we got labs again, for example, we're following hormones, we'd get another glucose and insulin. It's only helpful in understanding and tracking what's going on. Now, the insulin it's an interesting case that's tied to glucose, clearly. And helps us understand to what extent the brain is involved in all of this, not just the blood and the pancreas and the stomach, but the brain. When the brain perceives a famine, either because of restricting or over-exercising or both, not only does it shut down the hormone system, which is why you see these low hormones when you check them, it does not want you to reproduce in a famine. It turns down the insulin. And this is called the selfish brain syndrome. The reason it's doing that is it's going into survival mode, where it's prioritizing its resources. The brain is an organ that can metabolize glucose absent insulin. The muscles need insulin to utilize glucose as a source of energy. So the brain turns down the insulin centrally to starve the muscles so that it has access to all of the glucose. And understanding that is just one more way to gauge severity of illness. You see a very low insulin, you see a low glucose, you see the hormones turned off. It doesn't matter if she still weighs 200 pounds. That is a problem.
Wow, thank you for that explanation.
Sure.
I had never heard it put that way. That was really a good medical explanation of what's happening. It's really helpful for parents to know these things. Thank you. We did have a comment I just wanted to share with you in the chat so you'll know. Someone has said that they really appreciate this information as a crisis center counselor, and it will be truly beneficial when dealing with students who have an eating disorder. So very helpful for that participant.
I'm happy.
And then, yeah. And another question that came up is, do you have any advice for parents if there isn't a historic growth chart in their child's file? Is there anything that you can do kind of to maybe give the physician information if that's not available? I know there are some people that don't have that tracking over time.
Well, that is a great question. It's a big problem. And actually, the obsession, you might say, with growth charts is a very American pediatrician thing. Overseas, I trained overseas, so overseas, it's not as usual as it is here for pediatricians, family doctors, PAs, nurse practitioners, and so forth, to be charting a child's growth longitudinally. So you may not have that. When you're setting weight goals, then the critical number is, what did they weigh before they got sick? So we call that the pre-morbid weight, when they were happy and functioning and before the eating disorder developed. You, with some exceptions on the far ends of the scale, you will likely need to return the child to at least that number in order for them to function again. Now, it's a complex issue, but for the vast majority of kids, they're going to be returned to a minimum of their pre-morbid weight, remembering that weight is a moving target in childhood, right? So if she developed her eating disorder when she was 12, and now she's 16, and the highest weight she ever achieved was when she was 12. Now, obviously, a 16-year-old cannot weigh what a normal 12-year-old weighs. It's good. They're going to have to go up. But you could look at the percentile at which, if you know that number. But if you have no numbers, access to no numbers, then family history becomes critical again. It's always critical, but these are inherited brain disorders. Eating disorders are highly heritable brain disorders. Take a look at the child's closest genetic relatives. What is their body habitus? Are they tall and stout? Are they thin and small? Are they everything in between, right? You can't return a child to a weight that doesn't represent their own genetic potential. I mean, you can, but you're not going to achieve what you need to achieve. And it is much more likely that you will guess too low than that you will guess too high. And that's where those labs are so useful. If you're weight restoring a girl, a 16-year-old girl, say, who's been sick for 2 years and hasn't had a period for a year and a half, you start weight restoring her, and not only has she achieved periods again, but trust but verify, you're getting the estradiol, FSH, and LH, and they are normal, you're there, regardless of what the weight is.
Okay, thank you. That's really, really helpful. Another question, if there was one thing you would want every parent to remember when seeking medical treatment for their child's eating disorder, what would it be?
I think it would be that you are the expert in your own child. Trust your parental instincts and fight like heck.
In addition to that, if you have parents, I just remember how I felt when my daughter first got sick. I kind of lost my confidence as a parent. So even though I'd always trusted myself, how do you tap into that mother instinct or that trust of yourself when you're feeling so insecure?
Oh, goodness. That is really so well put. I just, even outside the world of eating disorders, when I was a general pediatrician, I would see parents who, I'm thinking of a mother who lost her 8-year-old boy to a terrible infection. She completely lost her confidence in herself as a mother. Why didn't I see it coming? Could I have prevented it? You know, should I have brought him to the doctor sooner? Did we wait? The whole thing. And the only thing I can say is parents don't cause eating disorders. Children don't choose to have them. These are in many ways random blows of fate, and you are the warrior who is most important in this fight for your child. You, and you alone.
That is so helpful. Thank you so much. Really appreciate that. And someone is asking, how long does it take for you to see orthostatic vital signs normalize?
A lot depends on how sick the child is, but in general, they normalize fairly quickly with adequate food intake and rest. You have to stop exercising. And that is much harder than it sounds. It sounds easy to say stop exercising. It's probably the #1 thing that parents struggle with, because exercise is the sacred cow of American life. It's considered all good all the time in every circumstance, and it's just not true. These kids
Do you
need
have
rest.
do you have pointers on how to stop exercise when there's compulsive exercise involved in the eating disorder? Any suggestions for parents? Is it just the supervision like
Well,
around
yes,
the clock?
absolutely. You have to have 24/7
Yeah.
supervision, no two ways about it. And sometimes the only thing that works for us is, so here's the deal, honey. You say this in as neutral a way as you possibly can, non-judgmental, neutral, supportive. It's my job to keep you safe. If you can't stop the anxious thoughts that are forcing you to exercise, I need you to drink a boost. I'm going to count to 3. And if you're not sitting down with your legs quiet, I need you to drink a boost. 1, 2, and always mean what you say.
Again, that's so helpful for parents to hear it spelled out like that. Just really, really practical ways to address these things that we definitely don't know at the beginning of an eating disorder. So thank you so much. We have a really important comment in the chat that one of the participants is a physician, had an eating disorder in their youth, and then did not recognize when their daughter developed an eating disorder. So I think that's That's fascinating that it's sometimes easy, even for medical professionals, to not see that it's developing, and even someone who has the experience as a recovered person.
Well, I can imagine there are a lot of reasons why that could happen to you. You don't be so hard on yourself. I mean, for one thing, if you've been through it and you start to see signs of it in your child, your brain is going to be like, no, 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 this can't be true, right? But it, you may be a physician, I'm a physician, but we're also people first and parents first. I thought I saw a question flash by about 6 months period.
Yes, that's the next one up. I'll read you that one.
All right.
You said 6 months for a period to return after weight restored is too long. What would you say is a normal time for a period to return after weight is restored? And also, if they're weight restored but can't stop exercising, will that delay their periods returning?
Last question first. Absolutely. And the reason for that is exercise suppresses leptin. Leptin, low leptin suppresses LH. Low LH suppresses ovulation, no resumption of menses. This is why you have to not exercise far longer than anybody is happy with. I would say, so how long does it take? Really, honestly, once, barring a couple of outlier metabolic issues, for the average person, girl, once they've achieved LH higher than FSH and an estradiol that's adequate, preferably like in the hundreds, but 90, 100, whatever, it's going to be, within weeks. The brain has got to be convinced that the famine is over. It can be very hard to convince, and exercise will absolutely derail that.
Yeah. Thank you.
Mm-hmm.
And someone is asking about, is it possible for you to give any advice on tics, repetitive behaviors that appear after an anorexia diagnosis? And this is specifically in a 12-year-old, and possibly how to reduce those or stop those.
Oh, no, I don't think I could give you advice about how to reduce those or stop those. That is a separate diagnosis, probably related to underlying anxiety, maybe OCD. But I get tick specific advice from your primary care provider.
This participant lives on a small island with very poor care that isn't really up to date and doesn't get much help at all. So it sounds like just looking for resources around anxiety disorders and
Well,
things like that.
remember, you can actually, tics would not be my specialty, but if I lived on an island and I needed help with that, I would see if I couldn't get a virtual assessment and some virtual advice, rather than just going locally where it sounds like you'd have a restrained.
That's a great idea. That's a great idea. Get some virtual help.
Mm-hmm.
Thank you.
Yeah.
And then also, Dr. O'Toole, another question, is there a time frame for how long the cognitive recovery lags behind physical recovery with eating disorders? Because I know that can be one of the most frustrating things for parents when they see that the weight has gone up. It appears to be that they're back, on their growth curve or above, and the disturbing extreme behaviors are still happening, or the psychological symptoms are still happening. So sometimes having maybe a general time frame, not a perfect time frame, but just a general one of when you can expect that to
Oh
improve.
gosh. Well, first of all, make sure that weight recovery is actually present. And that means normalization of vitals, normalization of labs, resumption of menses, normal periods in a girl old enough to menstruate is the most important biological marker of actually being where you need to be that we have. psychological recovery is going to lag possibly even years behind physical recovery. But if you don't get weight restoration, you will get nothing. So build the foundation of the house and then take your time building the house. And I think also we have to remember these are brain disorders, poorly understood. We don't understand exactly what went haywire in the first place. And when the biology of an illness is not well defined, it's very hard to know what to do. But we do know that what we can do is keep the eating disorder from trashing the life of this child by returning them to normal, forcefully returning them. We all know about that, how hard it is, to normal physiologic functioning so that their brains have a chance, they have something to fight back with as they try to navigate the next couple of years and quieten the thoughts that they do not ask to have.
Yeah, thank you so much, Dr. O'Toole. That was our last question. I just want to reiterate just how helpful this has been, all of this information, and just the supportive way that you address the parent's role. It just makes such a big difference to us as parents out there doing the best that we can. We really, really appreciate providers like you that support us like that. So thank you so much. And thank you again to Kartini Clinic for sponsoring this webinar. And thank you all for being here and participating in the webinar. We rely on your generosity to operate our services and programs. So if you enjoyed this webinar or any of the other resources that F.E.A.S.T offers and you're able to donate, there's a link there on the slide. We would really appreciate that. And we also hope that you'll be able to join us next month for our webinar on when FBT alone may not be enough, adding DBT into treatment, and that will be on Wednesday, the 6th of August at the same time that this one occurred. Again, a quick final thank you to Dr. O'Toole and Kartini Clinic. Really appreciate you, and we hope to see you next time.
Thank you. My pleasure.
Bye, everyone.